activated lecture of thyroid gland. The applied anatomy we already covered. We just touch upon quickly that the three-legged fascia covers the thyroid gland and is also attached to the thyroid cartilage. Therefore, when the thyroid cartilage moves up, thyroid swelling will also move up. That is during deglutition. If a midline swelling in the neck moves up on deglutition, it can be either a thyroid gland or a thyroglossal cyst. Remember, thyroid gland develops from the foramen cecum of tongue. But thyroid gland gets disconnected from foramen cecum of the tongue. The thyroglossal cyst, persistent to thyroglossal duct, is still connected to the tongue. So midline swelling of the neck, which moves up on deglutition and also moves up on protrusion of tongue, that's a thyroglossal cyst. A midline swelling that moves up on deglutition but does not move up on protrusion of the tongue is a thyroid swelling. A swelling in the neck which neither moves on protrusion of tongue nor on deglutition is a lymph node swelling. So that's how you differentiate the three swellings. Thyroglossal cyst, thyroid gland, and lymph node of the neck. Thyroid gland has got its blood vessel venous plexus inside the true capsule. So the thyroid gland is removed, it is removed with the true capsule. Because you don't want the true capsule to be torn because the venous plexus lies immediately below the true capsule. But false capsule need not be removed, because the venous plexus lies deeper to the true capsule. Compare this with the venous plexus surrounding prostate gland in abdomen. The venous plexus of the prostate gland in abdomen lies outside the true capsule but deeper to the fascia covering prostate. So thyroid gland venous plexus lies deeper to true capsule. So the gland is removed with the true capsule and false capsule is not removed. In prostate, because the venous capsule lies between the true capsule and the fascia, you have to remove both of them together. So the blood vessel between them is also removed. You don't try to separate the true capsule from the fascia covering prostate, but you leave behind the true capsule in thyroid gland. It should become as high as possible because the answer cervical supply that comes from below. A thyroid swelling can press upon larynx and trachea to produce breathlessness, which is called dyspnea. When trachea is pressed, it can press upon esophagus. When larynx is pressed, it can press upon pharynx, which will have difficulty in swallowing, dysphagia. When thyroid is removed completely, parathyroid will also get removed, will also get removed. So that's the result is hypoglycemia. Recurrent laryngeal is like the tracheoesophageal groove can get compressed, irritated, which will result in dysphonia. Dysphonia, which is difficulty in horses or what. Remember, spoken speech has got two components: sound, phonation, and articulation, and the movement of the larynx, etc. So, sound production faulty, dysphonia; articulation problem, dysarthria. Dysarthria is not there, this will be dysphonia. If you look at the two main arteries supplying the thyroid gland, superior thyroid artery descends down onto the gland. Inferior thyroid artery initially rises, but later on it descends down onto the gland. Effectively, both the arteries enter the thyroid gland by descending downwards. So if the goiter, swelling of thyroid, has to be moved during surgery, it should be moved up, so that you don't stretch the blood vessel supplying the thyroid. And the superior thyroid artery is closely related to the external laryngeal nerve. Care has to be taken to don't damage the external laryngeal nerve while ligating the superior thyroid artery. They are away when the thyroid gland artery enters the thyroid gland. So therefore, when you clamp the superior thyroid artery, clamp it as close to the gland as possible. In fact, people say, ligate the superior thyroid artery at the superior mole of thyroid, include the superior mole also. So that you are sure you will not damage the external laryngeal nerve. In contrast, inferior thyroid artery close to the gland is related to the recurrent laryngeal nerve. Away from the gland they are not. Ligate the inferior thyroid artery as far away from the gland as possible, but only one of them. Inferior thyroid artery supplies both the parathyroid glands. If you ligate both the inferior thyroid arteries far away from the gland, all the four parathyroids go off. So, when you are ligating, when you are doing heavy thyroid activity, then you can ligate the inferior thyroid artery as far away from the gland as possible, so that you don't damage the recurrent laryngeal nerve. Also notice, recurrent laryngeal nerve is outside the false capsule, the prostate, the fascia covering there. And anyway, you are leaving behind the false capsule. You are removing only the thyroid gland with the true capsule. If you see the middle thyroid vein, it's an extremely short vein, entering a very large vein in the internal jugular. And this middle thyroid vein is not accompanied by an artery. If you clamp the arteries, the middle thyroid vein will collapse. It is anyway small, and if it is collapsed, you don't see it at all. And you remove the thyroid gland, suddenly your operative field will be filled with the Tansa-like blood of Tansa-like size blood. Then you realize you missed out the middle thyroid vein because you couldn't see. What was the soothing? Ligate the middle thyroid vein while it is still seen. The first vessel to be ligated when you are doing a heavy thyroidectomy or total thyroidectomy is to clamp the middle thyroid vein. Then you clamp the artery. So don't miss out a small way, but an important way, because running into a large blood vessel. Thyroid starts with the foramen cecum of the tongue, which is a junction of anterior two-thirds, posterior one-third of the tongue in the midline. From there it descends down. As it descends down, it passes in front of the hyoid bone. Then it goes back up behind the hyoid bone. Then it descends down again. One would wonder, if it has descended down the hyoid bone in front, why did it go back up behind the hyoid bone and descend down again? That is one story, the answer to which we don't know. Because why then, how do we say that it comes down in front of hyoid bone and goes back up? Has anybody seen it? Nobody has seen it. Nobody has seen it. We don't know why it does. We don't know who says that it does that way. Thing is, the remnants of thyroid gland can be seen in the tongue itself. That's called lingual thyroid. Remnants of thyroid higher up in the neck are seen both sometimes anterior, sometimes posterior to hyoid bone. The fact that there are remnants may be present anterior or posterior to hyoid bone means it has gone both in front and behind the hyoid bone. Then it descends down into the neck to lie at a place where it can be easily seen. But remember, small swellings of the thyroid will be missed because there is a strap muscle in front. You are often asked as a trick question, when you want to palpate the thyroid, will you extend the neck or flex the neck? Logic tells us you can extend the neck because the gland can be seen quite clearly. If that was the answer, I wouldn't have asked the question. Keep the neck flexed so that you relax the infrahyoid strap muscles which are covering the gland. By relaxing the muscle, a small swelling can be picked up. When a muscle is stretched during extension of the neck, it will press upon the small swelling which you will miss. To palpate the thyroid gland is a neck flex. When the neck flex, the space for your hand is less. Stand behind the person, feel from back, with the hands in front, and palpate the muscle. And anything which is descending can get arrested during descent or might over descend. If it over descends, you get a retrosternal thyroid. A retrosternal thyroid is not a problem, but retrosternal goiter is a problem. Enlarged thyroid. Anything which descends, there is testicular descent, ovarian descent. Anything which is descending may get arrested during descent or over descent. Anything which is ascending might over ascend or might not ascend at all. Kidney is a structure developing the pelvis and ascends up to the abdomen. It wants to be as close to the heart as possible so that you get more perfusion pressure. In that posterior lateral part of diaphragm, tends to develop, which is developing from thoracomedullary membrane. Kidney ascends up into the thorax. Whatever can ascend up, but over ascend. We already discussed this tracheostomy can be high, mid, low. Preferable is mid, where you cut the isthmus and do a tracheostomy there. The alternative is, if you are skillful enough, you can go between the arch of cricoid and the thyroid cartilage. That's called as cricotomy, which is relatively less vascular, no thyroid coming in the way. Scalenus anticus syndrome is the old name for scalenus anterior syndrome. We discussed the axis the other day. Contract the cerebral mastoid on the opposite side, horizontally. So if you are turning the face to the right side, left cerebral mastoid and right scale goes into contraction, which can squeeze the subclavian artery. Therefore, radial pulse will be suddenly diminished movement to turn the face. When you put your hand in extreme cold water, you put your hand in extreme cold water, your hand immediately becomes pale. That's vasoconstriction. After some time, you remove the hand from the water, blood rushes to the hand. The blood rushes to the hand and the tissues of the hand were hypoxic because of the earlier vasoconstriction. Suddenly they will take up all the oxygen that is available now, and the capillaries of the hand will become deoxygenated to a large extent. When capillaries become deoxygenated beyond 5 grams per cell, those capillaries and tissue will appear bluish in color. That's called cyanosis. And after the blood vessel keeps on coming more and more, the tissues are no longer hypoxic. The hand will become pink because of increased vascularity. So what is the three things you do? You put your hand in extreme cold water, the hand becomes pale because of vasoconstriction. Remove the hand from the water, vasodilatation, and because of the hypoxic tissues, more deoxygenation of the capillaries, bluish in color. So pale, cyanotic, and then pink. That is the blood vessel has washed away all the deficient of. These three things happening one after another sequentially is called as Raynaud's phenomenon. And some people who are overly susceptible. For us, there may not be much. So those who are having extreme susceptibility, then you will see the classical triad of Raynaud's phenomenon. So what you have to do in such a case, that's the problem, especially in cold countries, where you did not even have to put a hand in cold water. The temperature outside is anyway -4. So the vasoconstriction is to be prevented. You cut the sympathetic nerve, which are causing the vasoconstriction. Hand is supplied by T2 to T6, but easily accessible at C1. If you try to cut the T1 or the fibers of sympathetic chain above T1, you get Horner syndrome, because T1 is primarily meant to supply the head with. So you get stenosis, constriction, meiosis, anhydrosis, lack of sweating, enough eyeball, sunken eyeball and all those. So you have to make sure that you spare the T1 ganglia and cut the sympathetic chain below T1. Otherwise you will have Horner syndrome. Parotid swelling, you already discussed this earlier. The most superficial structure, what is seen below here, is the facial nerve, which is running translucent to the parotid. The incisions on parotid will be translucent. Whereas the skin over the parotid is supplied by right auricular nerve, which is running vertical. Incision on the skin over parotid should be vertical. People what they usually do is take an incision just in front of tragus, then take it behind tragus under the external altimeter, and then take a large loop and go through the middle of the cerebrospinal. It's called as lazy S incision. So that the scar, whichever is there, will be minimal on the face and be covered by the bearded area. The hair can cover that. Take a vertical incision in the middle of the face, that is an angry scar. We discuss about how the incision should be. Over the parotid transfers any surgeries over parotid or any penetrating injuries over parotid. The inferior salivary meter muscular somewhere near that otic ganglion. Otic ganglion also has got sympathetic fibers. In the damage, penetrating injury, the sympathetic fibers which are supplying the sweat glands of the skin and the parasympathetic fibers which are secretomotor to the parotid gland may get crisscrossed. So sympathetic fibers will supply the parotid and do nothing. Parasympathetic fibers will supply the skin and cause sweating. So the thought of food or the you are eating food, naturally salivation occurs, and that's mainly through parotid, because parotid secretes the enzyme. Suddenly you find, instead of parotid secreting saliva, the nerve is now stimulating the sweat gland, and you get sweating over the skin over parotid. That means that's called Frey syndrome. Crisscrossing of sympathetic fibers supplying sweat glands of skin with the parasympathetic fibers supplying the parotid. Squid is the English word whose medical term is strabismus. So you sound more learned. If the angle between the two visual axes are not parallel to each other, that's called squint. You can get one eye looking straight ahead, the other eye instead of looking straight ahead looks outwards. You call it as lateral diplopia, lateral squint, divergent squint. If one eye looks straight forward, the other eye looks medially. It's called convergent squint. Irrespective of whether it's divergent or convergent, you will get double vision, because one eye macula sees one object, the other eye macula sees the other object, and macular representation gets two images. If the angle between the normal eye and the affected eye is fixed, non-parallel, fixed and non-parallel, in which case what the brain does, it suppresses the image of the abnormal eye. I repeat again, if the angle between the visual axis of one eye and the other eye are non-parallel but fixed angle, and irrespective whether you move to the left, right, up, down, If the angle between them remains fixed, the brain learns to suppress the image of the faulty eye so that you don't get diplopia. However, if the angle between the two eyes, angle keeps on changing when you move the eye left, right, top, down, the brain does not learn whose image should be suppressed and doesn't suppress any image. That's the time you get diplopia. Diplopia will occur when there is paralysis of a muscle. Let's say lateral rectus supplied by abduction is paralyzed of my right side. So the right eye will unimpose action of medial rectus. Right eye looks medially. So when the left eye looks forward, right eye looks medially. Now I try to turn my eyes to the left. Left eye moves laterally because that's forward. Right eye is looking medially always because of the paralysis of lateral rectus. Suddenly, the two visual axes become parallel. The diplopia disappears. So if I turn my eye, normal eye, to be parallel to the affected eye, the diplopia disappears. If I try to turn my eye to the right, left eye will adapt. Right eye can't adapt. The diplopia worsens. Because now there are right angles. So I look straight ahead, there is diplopia. If I attempt to look to the left, diplopia disappears. If I attempt to look to the right, diplopia worsens. So that is what is there. When do you get fixed angle? It is also called as concomitant speed. Suppose there is a tumor of the maxillary hair sinus. Maxillary hair sinus is below the eyeball orbit. So maxillary hair sinus swelling grows upwards, then you push the eyeball upwards, that eyeball upwards. Suddenly you find that one eyeball looks straight ahead, the other is pushed upwards. So the visual axis is no longer parallel. But even if it is pushed upward, it will move to the left, right, up, down. But again, the left eyeball is at a lower plane, right eyeball is at a higher plane, the visual axis will not be parallel. And the eyes will move left, right, up, down, but they will remain non-parallel always. They will remain of a fixed angle always, concomitant split. No diplopia, because suppression of quality. If the left lateral rectus is paralyzed, you get a sharp image, the vertical line, and you get a faulty image, the dotted line, to the left of the normal image. You get a sharp image by the normal eye, and the dotted line is a hazy image, which will be seen to the left. If the right side is paralyzed lateral rectus, the sharp image will be on the left, and the faulty image will be on the right. So, based on, in contrast, if you look at the lower one, superior oblique is paralyzed. The faulty image will be tilted medially in both the cases. Likewise, you can work out what will happen if superior rectus alone is paralyzed. What will happen if inferior rectus alone is paralyzed, and likewise. I have given you only two examples because these two muscles can get isolatedly paralyzed because they are separate muscles. The diplopia of lateral rectus is not as bad as a diplopia because of superior oblique. Because suddenly you not only get double vision, but they are tilted to each other. That diplopia is very bad. To counteract that, the head should be positioned in such a manner that when the head is tilted to left or right, eyes will tilt, eyes will undergo torsion. In this case, you will see on the left side superior oblique, the image is torsion medially. Turn the head to the left side, the right eye will extort. The right eye will extort, left eye is already extorted, then the visual axis becomes that. So tilting of the head gives an improvement to the diplopia of superior oblique. When you are extracting a tooth, you have to anesthetize the gums, outer gum, inner gum, and you have to anesthetize the teeth sockets. Outer and inner gums can be easily anesthetized either by injection or via cream. Apply cream is very impalatable. You don't tolerate if you don't want to tolerate an injection. And that cream is percolating enough to block the teeth sockets also. So apply cream on the outer gum and inner gum, it will percolate enough to enter the teeth sockets and anesthetize the teeth sockets so you can avoid the injection. This is true for upper jaw. For lower jaw, incisors and canine, the bone is sufficiently thin enough for the anesthetic agent to enter the gums without injection. However, for the molar, the bone is quite thick. Just anesthetizing gums is not enough for the injection to enter the teeth sockets. So you can't enter the teeth socket directly. So you have to go to find out what is the nerve supply to the teeth socket of the molar teeth. You find that the answer is inferior alveolar. When can I get the inferior alveolar? Before it enters the mandible. So you palpate on the inner part of the ramus of the mandible through the mouth open. Feel for the lingula of mandible. Above that is mandibular foramen. So put an injection above the palpated lingula so that you have blocked the inferior alveolar before it has entered the mandible, and therefore you can now safely extract any teeth of the lower jaw. We will also discuss dislocation of mandible. Notice the left mandible seen from the lateral aspect. Just anterior to the socket is an articulative work. When you open the mouth, the head of the mandible moves forwards. If it moves too much forward, it will go beyond the articulative vertical. And if it goes beyond the articulative vertical, vesical contraction will keep it up. Now the head can't slide back. Mouth remains open. So for that, you have to apply warmth to release the spasm of the muscle. Push down the third molar, along with that you push down the entire mandible. Gently slide it back into the socket. Remove your hand before you bite your finger and tie the top of the head and lower part of the mandible. That doesn't reopen the mouth for 7 days. Superior salivary reflex through the zygomatic or temporal nerve, which communicates with the lacrimal nerve from ophthalmic and goes to the lacrimal nerve. The same telegomerator ganglia gives pharyngeal gland, nasal gland, and parietal gland. So supply the glucose out in the pharynx, so shorted hard palate and nasal cavity. If you have got allergic rhinitis, hay fever, Your nose will start secreting. Open the mouth, there will be a pharyngeal drip because of software excessive secretion. You will also have tears building down. So, allergic reaction to the pollen in people who are susceptible irritates the pterygoballs and ganglion and all the glands which are supplied by pterygoballs ganglion. That's why, like lacrimal secretion, nasal secretion, oral drip, pharyngeal drip, and all those. So, that's ganglion. It is also called as ganglion of Hayflick. Submandibular gland. There is a question mark before the gland. There are submandibular lymph nodes also. Are lymph nodes gland or they are not gland? You call it as lymph gland. Whether you want to call lymph node as gland or not, enlargement of lymph node is lymphadenitis. And aden means gland. So, to differentiate the lymph node from the salivary gland, we have to call it as submandibular salivary gland. So, submandibular gland can also refer to submandibular lymph nodes, lymph glands. To palpate the lymph node, you can palpate from outside. To palpate the superficial part of the salivary gland, you can palpate from outside. You will not be able to differentiate whether it is a lymph node swelling or a glandular swelling. Submandibular lymph node has got a deeper part, which is between hyoglossus and mylohyoid. If you can manage to put the finger between the mylohyoid and hyoglossus, you could palpate the inner part of the gland. People. Mylohyoid is quite deep. How to insinuate a finger? Now, what you can do is put a finger inside the oral cavity proper, below the tongue, and on the side of the tongue. Below and to the side of the tongue. Remember, hyoglossus starts from hyoid bone and inserted to the side of the tongue. Mylohyoid is the oropharyngeal diaphragm, which is below the oral cavity. Putting a finger by the side of the tongue, below it, you are effectively in the plane between mylohyoid and hyoglossus. Then you can palpate the deep part of the gland. If the gland is enlarged, both parts will enlarge. So one hand on the outside of the jaw, one hand inside, one finger inside the oral cavity. If you press one, the other will get pushed. Push the inner one, you bulge outward. That means a single piece is what is moving. That's submandibular salivary. The lymph node cannot be palpated from within. So if you feel a swelling within and outside, it's salivary gland swelling. If it's just the outer swelling, it's a lymph node swelling. That's why submandibular salivary gland palpation is called as bimanual palpation. Where you are using two hands to palpate both parts of the salivary. Ideally, it should be called as bidigital palpation because you don't put the whole hand in the mouth. But still, because two separate hands are used, we call it as bimanual palpation or submandibular salivary. 4 arteries reach the septum of the nose at a particular area which was described by a scientist called Little. Little's area. 4 arteries which reach there are anterior ethmoidal artery, a branch of ophthalmos. But its posterior does not reach there. But posterior communicates with anterior. indirectly it has reached there. Then there is the sphenomegalan artery, which is coming from the pterygomegalan fossa, a branch of maxillary, which is the branch of external thoracic. The greater megalan artery, a branch of maxillary, which is the branch of external thoracic, and central branch of facial artery, which is the facial artery is the branch of external thoracic. And ethmoidals are branches of ophthalmic, which are branches of internal thoracic. So these four arteries meet in an area called Little area. The plexus of vessels there was described by another scientist called Kieselbach. It's called as Kieselbach plexus of artery. This is the area which bleeds quite often in bleeding from the nose. The treatment, if it is this area which is bleeding, it's pretty easy to treat temporarily by pinching the nose. That will automatically block the vessels. When it's a deeper bleed because of other vessels, then it's a tough job. And let the ENT surgeon. All except frontal air sinus opens into the nasal cavity at their upper end. Frontal air sinus has got its opening into the nasal cavity at its lower end. Infective fluid, therefore, can accumulate in air all the paranasal air sinuses, ethmoidal, sphenoidal, or maxillary, because their opening is at the upper end. Whereas frontal air sinus, infective fluid will not accumulate in the frontal air sinus because their opening at the lower end. That is good. So you don't get recurrent frontal sinusitis. Reinfection is possible, but recurrence does not occur. It can occur in all the other three sinus unless you do exercise like standing upside down and all those. People often don't do. You wonder why did nature make the opening of the air sinus at the upper end? Therefore, recurrent sinusitis is a big problem. The answer is, one of the jobs of the air sinuses is to warm the air, increase surface area to warm the air. The air, cold air goes into the sinus, gets warm, warm air rises. Luckily, the opening is at the upper end. That warm air can come back. Wonderful design of paranasal air sinus. But suddenly you wonder, why was frontal air sinus doing wrong? Cold air goes into the frontal sinus, gets warm, warm air rises, and it searches for an opening which is not there. The answer why, all the way while we thought that frontal air sinuses were well designed by the opening at the lower end, so that recurrent frontal sinusitis does not occur, and all the other sinuses were designed wrongly. Suddenly we realized the frontal sinus is designed incorrectly. Other sinuses were properly designed. Now nature does not make a mistake when it is designing the human body. But remember, human beings are slightly modified earthworms. Consider a camel, for example. Let's not go all the way to earthworms because they don't have paranasal air sinus. But camels have. The superiormost part of the camel, excluding the hump of the camel, is the mouth. When the nose is the highest level, all four air sinuses, including frontal, has got the opening at its upper end. So the frontal air sinus also opens at a higher level, the nose. So what has happened? We have turned our face at right angles to the rest of the body, suddenly we feel frontal SNF is wrongly designed. Ideally, we should be looking up. Why do we look forward? Because we have become a biped. From quadruped, mouth was at one end, nose was at one end, it could be raised up and down. And because we have become biped, we have to look forward where we are walking. We are not walking upward. The eyes are designed this way, head is turned, frontal eyes is wrongly designed. And instead, maxillary hair sinus, if it undergoes a tuberous change and the tumor rises upwards, it can affect the orbit. If it grows forwards, it will bring about a swelling on the face. If it moves laterally, it will produce a swelling on the face. If it moves downwards, it will invade the oral cavity. If it moves backwards laterally, it will invade the infratemporal fossa and irritate the mandibular nerve. If it grows backwards medially, it will irritate the maxillary nerve, the terticulated fossa. If it invades medially, it will cause erosion of the nasal mucosa and bleeding into the nerves. So this maxillary sinus grows in different directions and produces different signs and symptoms. The upper part of middle constrictor overlaps the lower part of superior constrictor. The upper part of inferior constrictor overlaps the lower part of middle constrictor. But the middle part of inferior constrictor, this area, is not overlapped by any structure, thyropharynx part. That's the weakening. And cricopharynx is a thick muscle by itself because of cricopharyngeal sphincter. And all constrictors are supplied by pharyngeal plexus, but cricopharyngeal sphincter is supplied by recurrent laryngeal nerve. A mismatch in the nerve supply because of mismatch in the receptive relaxation. When the upper part goes into contraction, lower part of the GI tract goes into receptive relaxation to allow the bolus of food to enter. Here, the upper part of middle constrictor goes into contraction, lower part also goes into contraction. Cricopharyngeal sphincter fails to relax because the different nerve supply, such mismatches are possible in some individuals. If it fails to relax, the middle part of thyroid, which is not overlapped by any other nerve, bulges out. So that bulging out is called as Killian's dehiscence. And that, where it is that bulged out portion, is called as diverticulum. Five branches of arteries supply toxins. The main blood supply is the branch of facial artery, which is called as tonsillar artery. Other than that, an ascending palatine branch of facial also gives a branch of toxins. Lingual artery gives a branch of toxins. Then maxillary artery, descending palatine artery gives a branch of toxins. A lot of arteries enter the toxins. Two from facial, one from lingual, one from maxillary, and one from ascending palatine. Then five arteries supply tonsils from different sides. During tonsillectomy, it's a tough job. You have to ligate 5 arteries. No, it's pretty easy. You can do what is called as guillotine tonsillectomy. Guillotines were those structures used in world wars where they used to execute prisoners. The neck used to be kept in the guillotine and a knife would come from up and chop the neck off. So you don't bother whether what is cut and what is not cut. The neck is severed off the head. Similarly, you just go and pluck out the tonsils. To hell with the 5 arteries like this. Luckily, all these 5 arteries supply the tonsil after passing through the muscle cover, the palatoglossus, palatopharynx, and superior muscle. These are the 3 covers of skeletal muscles through which the arteries pass before it enters, supply the tonsil. So by removing the tonsil, when you pluck out the tonsils, the muscles, skeletal muscles will go into contraction, which will automatically squeeze the blood vessels, all blood vessels at the same time. So the bleeding stops. If, however, one of the blood vessels gets clotted, that will not allow that muscle to go into full contraction because of the clot. Other blood vessels piercing the same muscle to supply the tonsil will not get compressed. Bleeding will occur. Normally, when a clot happens, you are happy and now there will be no bleeding. Here is the reverse. When the clot happens, you are worried because there will be continued bleeding. So remove the clots. When you remove the clots, before it clots again, the muscle has gone into full contraction. Bleeding is controlled. The removal of clots to prevent bleeding occurs when blood vessels pierce muscle before it opens into another region. A similar thing happens in uterus. The blood vessel supplying the endometrium of the uterus lies within the myometrium. If you empty the uterus, empty it completely, so that the uterus will go to full contraction, bleeding is subsiding. If a portion of placenta is left behind after delivery, that does not allow the uterus to go into full contraction, that will be postpartum hemorrhage. So anything, blood clot, placental part, or a cord part, anything which is there in the uterus will be completely removed to prevent bleeding. 2 places in the body, the palatine tonsil and the uterus. The 3 vertical muscles of the pharynx, palatopharynx, salpingopharynx, and stylopharynx. Remember, at birth, the opening of the larynx, lies in the nasopharynx. Opening of the larynx lies in the nasopharynx. That means the larynx is called an intra-aerial. That means there is no common oropharynx for food and air. Food passes through oropharynx, air passes through nasopharynx into the larynx way. So there is no chance for the food and air to mix with each other. There is no chance for the food to enter the larynx. So even if a newborn child drinks milk by lying completely horizontal, it does not choke. Because the larynx is the higher level. Later on, the lungs expand, trachea elongate, larynx descends down. Larynx descends down in the neck, giving back a common oropharynx, food and air passage. Food should pass to the laryngopharynx, air should pass into the larynx. So the filtration is done at that particular level, oropharynx. Which means if you try to stop and swallow at the same time, you are likely to choke. child also when it grows up is likely to show that it's drinking milk. He said, this is bad. Parents should have remained with the nasal cavity nasopharynx itself. So we can talk, speak, laugh, and swallow the food at the same time. What happens is, larynx produces sound. The supraglottic structure produces articulation. Pharyngeal for sounds like k, it's called as guttural sound. Soft palate for ch, hard palate for t, teeth for t, and lips for four. Are you getting the point? Supralaryngeal parts of the body converts the sound into articulation, words. The larynx is an intranasal, the supralaryngeal part, were only those three shells, bony shells, which are called as squawking, which don't move at all. So you can only produce whimpering sounds, like what a dog does. You see a dog or any such keen-scented animal, their larynx remains intranasal. So it can smell and swallow at the same time. But they can't produce sound. The sound will be either oral sound, or nasal sound. That's what the baby also does. It can't articulate because of that. Vocal apparatus is a higher level. And when the larynx descends down, the palatopharyngeal, which was otherwise horizontal, has become vertical. The larynx is down, palatal attachment. Few fibers of palatopharyngeal remains horizontal. It did not descend down with the pharynx, with the larynx. It remains horizontal. In a child who is born with cleft palate, milk enters the nasal cavity. Brain registers a wrong entry because nasal cavity is not supposed to. Nasal cavity or nasopharynx should not carry food body, including milk. Obviously, the cleft there in the hard palate is unable to detect it by the brain. Brain feels there is a leak of blood. And where is the leak occurring? Obviously to nasopharynx, the oropharynx. You feel that the milk which is gone into the oropharynx is now rising up. Why is it rising up? Because that nasopharyngeal sphincter, the communication between nasopharynx and oropharynx, is not being properly closed. If not being properly closed, the soft palate raises up, the horizontal part of palatopharyngeus goes into full contraction, tightly sealing that passage. But the gap is somewhere else. Hypertrophy of the horizontal fibers of palatopharyngeus, which can be seen as a swelling in the back of the throat in a child with cleft palate, was described by a scientist called Wasserman, and that's called a Wasserman examination. Infection of middle ear is called otitis media, but oto means ear. Look at the relation of nasal cavity. Superiorly there are meninges, above the meninges is the temporal lobe. So infection of otitis media, it spreads upwards. It can cause meningitis or temporal lobe abscess. Look at the relation posteriorly. There is sigmoid hair sinus, sigmoid dural venous sinus, and mastoid hair sinus. So the infection can invade through the posterior wall and infect the mastoid or sigmoid sinus. Infection spreading inferiorly will directly enter internal jugular vein. Infection coming laterally will rupture the eardrum and cause the posttrauma of the lateral aspect. infection does not spread medially because it's a bony labyrinth of the infection. So it can spread superiorly, posteriorly, inferiorly or laterally. What about anterior? Anterior is from where the infection enters. The eustachian tube, pharyngotympanic tube, auditory tube, three names for the same structure. By whatever name you call it, it communicates middle ear to the esophagus. Infection from the respiratory tract can enter through the eustachian tube to cause otitis. Remember, this eustachian tube is a 36 millimeter long, narrow, oblique passage in an adult. It is very less likely for nasal infection to become ear infection. But in a child, it is broad, straight, and short. So the child is happening that nasopharyngitis can produce otitis, which can eventually become otitis externa, appears in the ear. What is the time? 11:35. You've got some time to discuss a topic which is otherwise scheduled sometime later. But today is the last day that I can take a lecture. So after that we will be moving shifting to the fourth floor. Too far away from my hometown. It's like traveling to a different planet. So the other topic which is left is the joints of the middle ear. Yeah, joints are clear. Joints of the neck. And we are talking about the joints which are related to vertebral column of the neck. There is a joint between base skull and first cervical. First cervical vertebra is also called as atlas. And the base skull is occipital bone. The joint between atlas and occipital bone is called as atlanto-occipital joint. Atlanto. Atlas is become atlanto. Why atlanto-occipital and not occipito-atlantic? Because shorter word should come before the longer word. Occipital. Atlas. Atlanto-occipital. The two lateral masses of atlas form the joint with the occipital condyles. Because they are forming a joint with the occipital condyles, they are also called as condyloid joints. They are actually elliptical in shape, which is they are called ellipsoid joints. Don't confuse condyloid with condylar. Condylar joints have like knee joint and temporomandible, allows rotatory movements. Condyloid or ellipsoid do not allow rotatory movements. So atlanto-occipital joint allows flexion extension for 5 degrees, yes, or on the sides 5 degrees. So 5 degree forward backward, 5 degree lateral outwards. They are called flexion extension, lateral flexion on either side, which can also be called as abduction on either side. Because of midline structure, you don't call adduction, you call abduction on either side. You will say, I can flex to a greater extent, more than 5 degrees. 5 degrees occurs in atlanto. The remaining degrees occur with the remaining cervical joints. Then another joint, the next joint, in the cervical vertebrae, is a joint between atlas and the second cervical vertebrae, axis. Now you will feel atlas, ATLAS, axis, AXIS. Both are axis appears smaller. If you look at the sound, atlas, axis, both are similar syllables. And axis should have been actually spelled AKSIS, axis. Because there is a letter X, which is already KS, it appears axis is same size, a smaller size, and atlas. If there was a letter called TL, then you would have called it ATLAS, atlas. So both are same size. Now when they are same size, you have to choose first with the second. It becomes atlanto-axial joint. Because when they are same size, first bone is atlas, second is atlas, goes to something similar to sternoclavicular joint. Sternoclavicular. That's proximal and distal. Acromioclavicular joint. That distal and proximal. Glenohumeral joint. Proximal and distal. So, distal, proximal, distal, all those things occur where it comes to similar size words. Otherwise, smaller word should come first. The other word can come later. That's why atlanto-axial joint. Atlanto, N, don't be N as sound. Doesn't matter, the sound is quite good. I call it atlanto-axial, atlanto-axial. Atlanto-axial joint are three in number. Two lateral masses of atlas articulating with the superior surface of axis. This is the plane sinoid joint. More importantly, there is a median atlanto-axial joint, which is between the odontoid process of axis articulating with the anterior arch of atlas. Anterior arch of atlas is in front. Odontoid process of axis, the dens of the axis, is behind. And further behind that is the transverse ligament of atlas, the most important ligament in the human body. Transverse ligament of axis. The odontoid process remains in its place because of the transverse ligament of axis. Otherwise, the odontoid process would have fallen behind, crushed the spinal cord at C2 vertebral level, disconnect the respiratory centers of pharynx from the spinal cord C3, C4, C5 supplying diaphragm, and can cause death. This osseous structure in front and ligamentous structure behind acts like a ring in which the odontoid process axis rotates like a pivot. Median atlanto-axial joint is a pivot sinovial joint, and like the other two pivot sinovial joints, the superior radioulnar and inferior radioulnar, movement between atlas and axis is only rotatory. Remember, atlanto-occipital joint allowed flexor extension and lateral flexion, not rotation at all. Atlanto-axial joint does not allow flexor extension, does not allow lateral flexion, allows only rotation. So atlanto-occipital and atlanto-axial are complementary to each other. They allow complete movement. Both these joints together are called as cranio-vertebral joints. Cranio-vertebral joints. People often feel logically cranium and vertebral should be only the skull and first cervical bone. But first cervical and second cervical are also called cranio-vertebral because they are completing the missing movement of the head. So during rotation, the head and atlas acts like one unit which rotates, the ring rotates around the pivot. You are often asked, does the ring rotate around the pivot or the pivot rotates within the ring? What happens in upper radioulnar joint? The notch of the ulna and the annular ligament acts like a ring, osteofibrous ring. It is the head of radius is fixed. During rotation and supination, the radius rotates, the ring remains fixed. In the waist skull, the ring is fixed, axis rotates. No, the ring rotates, axis is fixed. So the two are not comparable with each other. But let's look at the only other joint, inferior radial joint. Inferior radial joint, there is a notch on the radius in which lies the head of ulna. So the notch on the radius acts like a ring. Head of ulna, this is the lower end, acts like a ball, the pivot. During pronation and supination, the radius rotates around fixed ulna. So inferior radial joint is again where the ring rotates, pivot is fixed. So you are asked, atlantoaxial joint is comparable to superior radial or inferior radial? During movements of the head, rotating movements of the head, the ring rotates, pivot is fixed. Inferior radial joint, pivot is fixed, ring rotates. So the comparison is between inferior radial joint and atlantoaxial joint. If you accidentally speak, atlantoaxial is comparable to superior radial joint, don't get disheartened. You say, this happens during judicial hanging. Then the head is fixed and the body begins. And the axis is rotating. The skull is fixed. So it is comparable few minutes before you are dead. But you are not wrong. As about the movements possible at these two joints. Other intercervical joints are like other interthoracic joint, interlateral joint. There are some degree of flexion extension. Whatever is the remaining flexion and extension possible beyond 5 degrees or intercervical, they allow rotation. The rotation at the craniovertebral is 45 degrees on either side. So you can move more than 45 degrees. The remaining headache is survival. After the movements, next question asked is muscles being involved. Now we know that there are rectus capitis posterior major, rectus capitis posterior minor in the suboccipital triangle. There was rectus capitis anterior in the prevertebral region. There was rectus capitis lateralis in the paravertebral region. And there is obliquus capitis, superior and obliquus capitis. All these are sufficient to bring about all the movements that are possible at these joints. But these are so small muscles, so weak muscles, that they act merely as stretchable ligaments. So all these fanciful names don't add to the movement. There are other bigger, better muscles and hormones. Flexion at the neck is performed by sternocleidomastoid. But the same sternocleidomastoid extends the craniovertebral. So you flex the neck and extend the craniovertebral, and what is called as peeping movement is that when both sternocleidomastoids act together. So then who flexes craniovertebral? Craniovertebral is flexed by gravity alone. We have seen people driving by SC buses and observe others who are sleeping. You notice, or train also. Head is going down, gravity. Suddenly, when those stretchable ligaments behind tell you, hey, overstep, he wakes up in the chair. And they are observing, he is embarrassed. But after some time, gravity alone performs the movement of the cranial extension, whether it's intracervical or cranial is done by deep muscles of the back. Erect the spinal group, and there is one more group, the transverse spinal group, the semi-spinalis group. We discussed semi-spinalis as a third peripheral heart. What was the first peripheral heart? Soleus. What was the second peripheral heart? Lateral to the body, which helps in improving blood circulation when you take a deep yawn. And then you will get stuck in the mouth open. Don't take a deep yawn. Breathe through the nose. And third peripheral heart is the semi-spinalis cavity, for the blood vessels, veins corresponding to superficial and deep cervical lie in the semi-spinalis cavities. So you need to extend the neck periodically. During the theory paper, to seek divine inspiration to get to know the answers of the questions. Cerebromasculine is not a peripheral heart, so curving the red inside and that side is not permitted during theory exams. Even practical also. But seeking divine inspiration. So that is the muscle which extends the neck, extends the cranial. Lateral flexion of the neck theoretically can be done by scalene, but is actually done by ipsilateral cerebromasculine. Ipsilateral cerebromasculine, which is flexing the neck, will also turn the face to the other side. If you don't want the face to be turned to the other side, there is a muscle on the back called splenius capitis. Splenius capitis of the left turns the face to the left. Left cerebromasculine turns the face to the right. So left cerebromasculine, when it acts with left splenius capitis, the rotation is cancelled. That is the lateral flexion. So such muscles as splenius capitis, which prevents the unwanted rotation of the cerebromasculine, are called as synergies. When the prime mover has more than one action at one or more than one joint, undesired unwanted actions are cancelled by muscles which are named as synergies. Flexion of the radius is done by flexor carpi radialis and flexor carpi ulnaris. Adduction of the wrist joint is done by flexor carpi radialis and extensor adduction is called the flexor carpi ulnaris and extensor carpi ulnaris. So flexor and extensor carpi ulnaris will cancel the flexion extension. That result is adduction. Flexor carpi radialis causes flexion and radial deviation. Flexor carpi ulnaris causes flexion and ulnar deviation. Flexor carpi radialis and ulnaris go into contraction. The radial deviation and ulnar deviation will cancel out each other, result is pure flexion. So, the undesired action of flexor carpi radialis during pure flexion is cancelled by flexor carpi ulnaris. And the undesired adduction component of flexor carpi ulnaris is cancelled by flexor carpi radialis. So both are synergies to each other, but both are also prime movers. So they are called as co-prime movers, co-synergies. Same is the case with adduction of the wrist. If you want pure adduction of the wrist without flexion or extension, flexor carpi ulnaris with extensor carpi ulnaris. Flexion extension cancels, Net result is ulnar deviation or adduction. Again, the flexion component of flexor is cancelled by the extensor. The extension component of flexor is cancelled by flexor. Cancel out the undesired action and synergies. And there are also prime movers. Home prime movers most. Let's come back to splenius capitis is a synergist to sternocleidomastoid during adduction. Actually, only the initial phase of adduction. After that, adduction is assisted by gravity. Scalene muscles can also adapt, but they are better. They better act as synergists when you want rotation of the neck without tilting of the head. Rotation of the neck to the right side is that your left sternocleidomastoid. The right scalene will prevent the tilting of the head. Left sternocleidomastoid acts with right scalene to rotate the face horizontally to the one side. So, ipsilateral scalenes cancel the unwanted and desired tilting effect of contralateral sternocleidomastoid. This is a synergistic action of scalene muscles. Well, as I said, there are muscles designed rectus capitis posterior nature. It's a big muscle, four names to it, and clearly acts as stretchable ligaments. For those small rectus capitis, whatever you want, they are all small, too weak when you compare it with sternocleidomastoid, scalene, splenius, semispinous capitis, and gravity. Can we stop here? 9 o'clock? 12 o'clock? And so, histology batch people will do histology lab at 1. What will the others reset? Okay.